Hello and welcome to On Call with Wayne Memorial. Today I'm here with one of our orthopedic dream team orthopedists, Dr. Allardyce. Hello, Dr. Allardyce. Thank you so much for being with us.
Well, thanks for having me.
Sure. So, Dr. Allardyce, tell us about yourself and what made you want to become an orthopedic surgeon.
That's a great question. You never know. I started out actually in electrical engineering, and that's how I got my undergraduate degree. But somewhere along the way, I just felt that wasn't it, and I wasn't done. There was an orthopedic surgeon from the small town in Avoca, where I came from, and I think he was a great role model. And I thought to myself, boy, that would be a great thing to do.
Interesting. And I know that you are at a bunch of different locations. So where can patients in our area find you?
Well, right now I have an office at the Cherry Ridge Clinic on Route 191, and I'm also twice a month at the Barnes Kasson Hospital, as well as Peckville in the Mid-Valley Hospital.
Amazing. So we can see you anywhere close to home.
I'm a traveling doctor. Yes, I am.
So today we're going to talk about orthopedic surgery and arthritis. So what drew you to orthopedic surgery, specifically helping patients with arthritis?
Well, again, getting back to how I got started, he was an orthopedic surgeon. So I obviously got into medical school. And it's interesting the way medical school works. Medical school is just the springboard. That's the beginning. Your real training comes during residency and fellowship. And when I start out in medical school, it's 2 years of basic science, and then you start your clinical rotations. But by the time you have to make a decision, you've only seen one or two specialties. So I thought going into medical school that orthopedic surgery would just be a good fit for me.
Perfect. And for those who may not be familiar, can you explain what arthritis is and how it affects your joints?
Arthritis, it's kind of a misnomer. It's inflammation when you hear the word itis, which means inflammation, but a lot of times I think it's more accurately described as arthrosis, meaning there's not active inflammation like infection or a metabolic condition like gout. And it's just basically wear and tear of the articular cartilage of a joint.
Okay. So how many stages of arthritis are there, and what typically happens in the stages?
Well, arthritis really isn't staged. It's more like a grade, and it's a continuum of disease, starting out from birth with nothing to the day you're in the operating room for knee replacement when it's severe. And there's a lot of different classifications. There's radiographic classifications when you look at an x-ray, and that's what most people see in the office is their x-ray. And there's a lot of fancy grading systems, but really it's mild, moderate, or severe, and it's based on how narrow the joint space gets, because that's crystal clear, it's black and white on an x-ray, and people can understand that.
And what are some early warning signs that someone might be developing arthritis?
Well, if you look into your family history, the single most important thing is your family history, your genetic makeup. So if you're predisposed to it, unfortunately, there's nothing you can do about that. That's an endogenous factor. The exogenous factors you can change, your weight, your activity level, etc. But the first symptom is going to be pain. It's simple as that. And that's usually why people come to the office to be evaluated.
That makes a lot of sense. When it starts to hurt is when you finally reach out to a doctor. And in the early stages, what kind of treatments or lifestyle changes can help potentially slow the arthritis?
Well, I'm kind of a foot dragger when it comes to treating patients, especially with what we do. We're called allopathic physicians, MDs. And everything we do, there are consequences, meaning there's risks with every decision we make. So I like to start off very slowly. Like I said, I'm a real foot dragger when it comes to this. And the first thing is lifestyle changes, okay? And a lot of those things, these exogenous factors, such as weight, diet, and exercise, they're the first things you really want to change before you start getting into medications or therapy or invasive things such as injections and certainly surgery.
Okay. So when arthritis becomes more advanced, what are the treatment options that you would offer a patient?
Again, I'm the great foot dragger, even when it's advanced. And I can tell you, because I'm sort of getting towards the end of my career, I have 30 years of private practice under my belt. Even the patients that I've had in the Medicare population with end-stage arthritis, I'd say probably less than half ultimately choose to have a replacement because they can cope with their condition. And that's the end, that's the last, is surgery. The first thing I would do as a physician would be, well, depending on the severity, stick a needle in it for diagnostic purposes. If it's a bad knee, take the fluid out, send it to the lab, see exactly what you're dealing with, or just start on an over-the-counter medication that people have easy access to. They don't need to go to a physician, such as Tylenol, Motrin, Advil, Aleve, even Voltaren gel. The 1% Voltaren gel is available without prescription, and that's a great place to start.
Wonderful. How do you decide when a patient might be ready for joint replacement?
There's no great answer to that, and there's no yes or no answer to that. There's no yes or no's in all of medicine, really, at least in our field, because we're not dealing with cancer or heart disease, a life or limb-threatening problem. This is a lifestyle-threatening problem. So the decision to proceed with joint replacement is made carefully. But I really put the onus on the patient, because it's like buying a car. Do you want to buy this car? Okay? And the reason is there's no guaranteed outcomes with any operation. In fact, there's an old adage, there's no operation in medicine that can't make something worse. Because if you have a complication, it can be very bad, and there is a dark side to surgery. Now, with that aside, if mutual decision's made and they want to proceed with surgery, you have to inform them about all the complications or potential complications, because it's a very long list of possibilities. And these things are things like bleeding that would require transfusion, or that would cause a heart attack or stroke. Infection, that's almost the bane of our existence, because we're putting an implant in a patient. It's a foreign body, and infections and foreign bodies don't do well together. Blood clot in the leg, nerve and artery injury, and then all the anesthetic complications that can potentially occur, such as pneumonia, again, heart failure, heart attack, stroke. And what's interesting is that, I just listed, say, 10 potential complications. A perfect operation and a perfect anesthetic can still be followed by every one of those complications.
Wow.
And that's really out of our control. So once you inform the patient and you feel comfortable that they understand the complications, potentially, the dark side to joint arthroplasty, if they decide, then you're comfortable proceeding. And usually the people who are most comfortable making a decision have tried everything else. They know nothing else worked. And that's why, going back to what I said earlier, I'm a foot dragger. I start with activity modification, diet, exercise, therapy, medications, injections with steroids, injections with gel or visco supplements, and then lastly, surgery. And it really should be in that order.
You give the patient a long time to lead up to that decision, for sure.
That's right. And that way, they're ready, I'm ready, because if something should go sideways, if you have a complication, then you can manage them because they understand all the possibilities.
And what's one piece of advice you often give to patients to help them stay active and stay positive when dealing with a diagnosis?
When it comes to managing patients, and let's say we have a diagnosis of arthritis and probably they're going to need a knee replacement, you like to keep them positive, just like the question. And the way you do that is you tell them that you're in it together, that you can't do it alone, and you would like for them to maintain a high level of activity, flexibility, diet. You want to prepare them for an operation, and the best way to do that really is weight loss, flexibility training, so that they have good bone quality, good muscle tone, and a flexible joint, because that makes for easy surgery. Difficult surgery is in a stiff joint, someone who's overweight with osteoporosis, then the outcomes aren't nearly as good. So you want them to be ready for surgery, but what's interesting is that if you can have them buy into that, a lot of them won't ever need the operation because they can cope with it, especially when it comes to weight loss. And I think if there's any one thing that's most important, if there's such a thing as the most important thing, it would be weight loss, because in terms of the mechanics of the knees, in the hips, there's something called joint reaction force. You just don't have your body weight across your joints. Muscles have to contract in order for people to walk or to get, for example, for me to get out of this couch. And the joint reactive forces can be as high as 8 times your body weight across the kneecap or 4 times your body weight across the hip joints. So that for every pound lost, there's a 400% return on the investment across the hips, or 800% across the knees. So people understand that very early on in their weight loss program. So that's something I kind of stress.
Definitely. Wow, I had no idea it was that high across your knees. Wow.
It is impressive, the forces across the joints, yes.
Wow. And what is, outside of medicine, what is something that you like to do to keep yourself healthy and your joints moving?
Well, if I'm selling this, you know, you have to be the consummate salesman. And I try to, again, maintain a nice balanced diet. I like to do some flexibility training. I ride a bicycle. I just stay as active as I can. And that way, I'm hoping for some longevity in this world after I'm out of the orthopedic field.
Definitely. And just a personality question. When you are headed into the OR, is there any music or any superstitions that you have, any rituals that you do before you operate?
I think if you asked every single person in our operating room, they would answer it the same way. There's no music and everything's out of the room. It's a clean room.
Wow.
Every time.
That's awesome. And is there anything else that we should educate patients and the community on regarding your knee health?
Well, again, I think we covered a lot of things, and flexibility, weight bearing, and weight loss. And I think what's important for people to know is that some people say, well, I need to rest my joint. Well, that's not accurate, because the hips and the knees, they're the 2 big joints. They're called synovial joints. And the way a synovial joint works, it has a lubricating fluid called synovial fluid circulating in the joint. And that's the fluid that provides nutrition to the cartilage cells, the cartilage, which is the smooth Teflon surface inside the joint. So in order for that synovial fluid to work, the joints need to be moving, and the cartilage needs to be compressed, and it needs to rarefact as well. So there's got to be compression and rarefaction of the cartilage, basically squeezing it to have that synovial fluid penetrate to the cartilage cells. There's no blood supply. So rest is the single worst thing for a synovial joint. And getting back to weight, when you get up in weight, you tend to get more sedentary and there's less activity. So it's not the impact that leads to joint damage, it's the lack of activity.
Wow. Thank you so much. I've really learned a lot today. Thank you.
Well, it's a privilege being here. It's a privilege being at Wayne, and I'm glad I had the opportunity. Thank you.
Thank you.